So to get us started, I'm going to pass the mic on to Dr. Pauly, who's going to talk about the work she's been doing through the ELPH project on enhancing organizational capacity for health equity. Bernie, on to you.
Thanks, Sume. Can everyone hear me okay?
Absolutely.
Great. I'm going to talk a little bit about some of the findings that have emerged out of a 5-year project on enhancing health equity and public health. And I want to acknowledge that I am doing this work and I'm located at the University of Victoria, which is on the traditional territory of the Lekwungen-speaking people, and that includes the Songhees, Esquimalt, and Wasanix people, whose historical relationships with the land continues to this day. And the photo that I chose for the land acknowledgement is one is actually on the university project and is an area known as Mystic Vale. And the traditional greeting that I shared with you is one that has been written by the First Nations people who have a long history with the land where we're located, and acknowledge that I'm a settler on this territory, and that I thank the traditional peoples for the opportunity to live and work here and to be able to do this work around health equity, which SANA has been a huge part of. I recognize that many of you are joining, and you may be very well steeped in health equity because it's such a core value and principle in public health work. But I also recognize that some people may be wanting to sort of learn and think about health equity. And so I often have used this slide to sort of give a bit of an orientation to how we understand health equity in this project that we've been working on called the Equity Lens in Public Health, and some of the kind of key distinguishing factors between equality and equity. And I will just say, I chose this metaphor, and there are many different metaphors that one could use to explain the difference between equality and equity. But I live in a family of people who all love to ride bicycles. They love to commute. They love to race. They love to play on bicycles. And we actually have one bicycle, which is called the ice cream bicycle, which my son puts the seat up on. So I struggle to ride it when he does that. And if I put the seat down, it's kind of like that guy in the middle on the top. So, you know, we're very privileged to have access to resources to be able to cycle. And you can see across the top, if everyone has the same bicycle, that's generally a way of understanding equality, but recognizing that we are all positioned differently because of our unique history, our way in which we are positioned in society differently because of how race and gender and other aspects of identity are positioned and constructed within society, that we actually, to achieve equity, need not only to have access to appropriate resources, such as the bottom slide, but we need to create a context in which everyone has access to resources as well, because even, you know, the bottom equity slide doesn't get at the point that we need to have the resources to have any kind of bicycle in the first place. So I think the WHO Commission, which is really core to our understanding of health equity and public health, stated this very well and highlighted the fact that a toxic combination of bad policies, economics, and politics is in large measure responsible for the fact that majority of people in the world do not enjoy good health that is biologically impossible, and pointed out that social injustice is killing people on a grand scale. They did not use the words structural violence, but if you're familiar kind of with that theoretical conceptual description of kind of the structural conditions in which some people are more vulnerable than others because of poor policies, it's very much aligned with what Michael Marmot is saying here. So inequities are systematic, they're socially produced, and they are unjust or unfair. And focusing on the fact that they are also modifiable. A really important background piece is that in 2011, the Rio Declaration, which took up further this focus on health equity, made a very important point that reorientation of the health systems towards health equity through action on the social determinants of health is needed. And that is exactly the kind of thing that helped us to really focus on the fact that while health systems in their current state do little actually to contribute to health equity, we have really important work to do to reorientate the health systems towards health equity. And in BC specifically, beginning in 2005, the provincial, at the level of the provincial health ministry, directed that public health should apply an equity lens across programs. And then they reinforced that in 2011 in the document you see on the left there, Promote, Protect, and Prevent, which also showed a framework for public health in which equity lens is to be applied. So we partnered with the health authorities, 6 of the health authorities in British Columbia, on a project, as well as the ministry, on a project called the Equity Lens in Public Health that was to guide and inform learning about the integration of an equity lens so that we could contribute to knowledge of health inequities reduction. But if I was rewriting this purpose today, we wrote this like more than 6 years ago when we were funded by CISUR to do this work, I would also add in to promote health equity, because there's 2 sides of the coin. There's reducing health inequities, but there's also promoting health equity. Here you see a picture of British Columbia and the health authorities that were involved. We began our work before the establishment of the First Nations Health Authority, but have maintained and developed a relationship with them ongoing, although they were not official project partners. And then, of course, NCCDH was one of our national partners, along with Public Health Agency of Canada. So what I'm going to just spend a few minutes very quickly describing kind of what we found that was limiting health equity, and then what we found was promoting health equity within healthcare organizations. And so you see before you a visual. We collected data in 2013, 2014 to get a sense of how people were understanding health equity and what a health equity lens, how it was being applied at this first point in time. And what you see here is a very diffuse equity lens where there's a lot of different understandings of what health equity is. And we've written a paper called Health Equity Talk, which describes this, where there's a variable focus on equitable outcomes, equitable access, talking language and social determinants of health, using language of vulnerable populations, ideas about closing the gap. And while we can see how these are all related to health equity, it often made it very difficult for people to know what a health equity lens was, what it actually meant, and then to apply it. And people also identified they had limited guidance for applying that. When we asked people at time 2, and that was 2015, 2016 across BC, what we found is that the health equity lens had focused in a very narrow way and become a very limited health equity lens that was very much focused on inequitable access and targeting vulnerable populations. And that was because we had lost universal programs that were available across the population. And we lost that focus on narrowing the gap. We lost a focus on equitable outcomes, except for in very targeted populations. And here is an illustration of the very powerful system constraints that impact organizational ability to do work around health equity. And you see around the rim of this funnel, biomedicine, individualism, corporatization. There is actually, I apologize because colonialism is on a newer version of this. But as a result of these kinds of forces that create the context in which health systems were both created and in which they continue to operate, we have values like efficiency and scarcity, a dominance on acute care, patient-centered care, and mandated programs. And so we could see really clearly in our data how these forces restricted work on health equity. So we also want to look at the flip side of this and say, how can we do work to promote health equity given our current context, and what kind of work is being done to shift systemic values? And we drew on complexity thinking and a complexity lens. And here you see a wheel that has kind of 6 features that were identified as strategies for making health equity a priority in organizations. And I'm just going to start to the left there where it says make health equity explicit. And so being able to state very clearly that health equity is a priority, to see it in mission, vision, and values, to see it embraced within strategic plans, and is very important within healthcare organizations in order to promote health equity work. But then moving to the right, also ensuring that there are clear equity-oriented goals and outcomes that are paramount to health equity accountability, and making organizations accountable. So funders making organizations, provincial funders, for example, making it explicit that health equity must be accounted for in the delivery of programs and services. Having health equity champions who can drive the health equity agenda, and we found in our work, medical officers of health were critical in that role and had that role. You have to organize for health equity. It has to be hardwired into all levels of the organization. And so having public health leaders, Aboriginal health leaders at senior executive health tables, having, representation in leadership roles and all through the organization. Having the data, so having health equity data and being able to mobilize population health data to both recognize where the health inequities are and how we can respond to them, and then investing obviously in health equity and resourcing health equity work so it's not being done off the side of the desk. So in our work, to help facilitate and promote health equity in organizations, out of this analysis and work, we developed what we call the SHELL, a systems level health equity lens that puts the focus both on actions to reduce health inequities, so recognizing and being competent in the social determinants of health and how those impact equity, but also recognizing the issues that are implicated in health equity around racism and many other forms of stigma and discrimination that occur. Sexism would be another example, and then also considering not only people's geography, but also their both physical and social geography. And that's really, we drew heavily there on Elizabeth McGivern's work, who's a nursing scholar, and we reference that in our documents. but then also putting a focus on promoting health equity, the piece at the top where we're looking at issues related to social inclusion and how we take action on both the material and non-material determinants of health, and who has access to what and who's represented. And that we do this across multiple levels, from public policy through to kind of at the individual level, and that we have a number of strategies related to health promotion, protection, disease and injury prevention, surveillance and treatment, and particularly drawing on the Ottawa Charter for health promotion. So that's a quick overview of some of our key findings related to organizational understanding what both restricts and facilitates organizational health incorporation of health equity. And you can find much more explanation on our website from those two. We have several knowledge translation, knowledge products that spell out in more detail what I presented today. So thank you, and I will turn it over to back to Sume.